તરફથી આવકારીએ છીએ. તમારા માટે સેશન રાખેલું છે. અત્યારે ડૉક્ટર રવિ સર અને ડૉક્ટર કિરીટ સરનું લેક્ચર છે. ઓન બિહાફ ઓફ અમદાવાદ મેડિકલ એસોસિએશન આપણે ડૉક્ટર કિરીટ પરમાર સરને પ્રોફેસર ઇન NHL મેડિકલ કોલેજ એમને મોમેન્ટોથી સ્વાગત કરીશું. ડૉક્ટર નિરાલી પટેલને હું મોમેન્ટોથી ડૉક્ટર કિરીટ સરને ફેલિસિટેટ કરીશું. ઓલ્સો આપણા વચ્ચે ડૉક્ટર રવિ ગદાણી સર, એસોસિએટ પ્રોફેસર ઇન બીજે મેડિકલ કોલેજ, એ આપણા વચ્ચે હાજર છે. હું ડૉક્ટર નિરાલીને કહીશ કે એમ તરફથી એમનું ફેલિસિટેશન કરે. થેન્ક યુ. તમારો લાઈવ સેશન સ્ટાર્ટ થાય છે. જે કોઈ તમારા ફ્રેન્ડ્સ બાકી હોય એમને ઇન્ફોર્મ કરી દેજો. 3 to 5 છે, ડૉક્ટર રવિ સર અને ડૉક્ટર કિરીટ સર. ઓકે.
Okay, good afternoon, everyone. My name is Dr. Ravi Gadani. I work as an associate professor in BJ Medical College, Department of Surgery. So, first of all, a disclaimer that your practical exams are quite subjective. We'll still talk about some foundational stuff which do not really vary between examiners, and that's what we will actually focus on. I'll first talk about the exam pattern in a minute, and then what's the general schema of history taking. We'll talk about abdominal examination, especially few pointers in it, few long cases, few short cases, and if time permits, some general advice from my side. So, you know, exam pattern, 80 marks is given to long case, which is the largest chunk, and then 40 marks each for short case 1, 2, and table. Total it is 200 marks. So, history taking, those who are from BJ Medical College may know that I have always said that you really want to go to the theory of your case. So let me rephrase this. Consider you have a case of inguinal hernia or hydrocele. Because you have read the books, you already know about how to maybe investigate and how to operate or which surgery to offer, what to speak at least, right? But in order for you to reach a level where the conversation, the examination or the cross-examination reaches where the examiner starts asking you about the investigation and management, before that, you will have to swim through the history and physical examination. If you are stuck there, then as I always say, you have 7 to 8 minutes, at best 10 minutes. And those 10 minutes are the ones that you have, not your examiner, right? Repeat, clear? Okay. So history ideally should flow like a story so that your examiner just wants to listen to you, ask few relevant questions in each section and go on, so that then we can reach the diagnosis and then maybe management. Clear? Okay. So first advice is do not say biodata, don't list the biodata, instead say a single sentence which says something like this: good morning sir or madam, I am presenting a case of 35-year-old Hindu married male, Mr. XYZ, resident of so-and-so place, so-and-so by occupation and hailing from this socioeconomic class. If it is relevant to your case, now this is a broad advice. This applies to your case of hernia also, and a case of ulcer also, and your case of hemiparesis in medicine and gynecology, wherever, right? So if you speak it like this, then if at all it is relevant to that case, your examiner may ask you 1 or 2 questions, right? But if you start saying patient's name is so, age is so, it is a male patient, that is not how you should speak history. Chief complaints, as you know, are at the most they are 2. Chief complaints are what brought the patient to you. So if the patient had abdominal pain for last 10 days, but if he developed vomiting for last 2 days, then the chief complaint would be complaint of vomiting, because it is when the vomiting started the patient felt like coming to you, right? So the same sentence that you said earlier, that can then be continued as and presented to the OPD or hospital on this date with chief complaint of abdominal pain and complaint of vomiting for so many days. Onset, duration and progress, once that sentence is over, you want to take a pause of a second or two so that if your examiner wants to ask you something or if you want to be asked, because you know, I know this part, then take a pause, no questions, go ahead. And then your next should be on elaborating the onset, duration and progress of the presenting symptoms. This has to go like this. You don't have to apply any brains in this, right? Talk about the complaint that the patient has. So consider the patient said that I have pain in abdomen and I have vomiting. So what is expected in onset, duration and progress is you would then go in details of each complaint. So if abdominal pain, you have to describe that abdominal pain, like, site and duration and if any relationship to meal and if there are any factors that relieve it, right? And what's the nature and what's the intensity, etc. Then you want to go to something that we colloquially call as negative history, which is not actually a negative history, but these are the symptoms that the patient told you that I have these two things. Now you think that in order to arrive at a diagnosis, there are few other symptoms that I need to ask for. So you may ask for history of constipation or you may ask for history of fever. But all of this and anything that you speak during your history, you should be able to justify. That is the bottom line, right? So if you think there is a question that you know that you need to ask, but at this point you do not know its mechanism, why you should ask it, you may choose to avoid asking that question. Past history is always spoken as known case of diabetes mellitus, ischemic heart disease, hypertension. These three things always ask. If relevant to your case, like PVD, ischemic heart disease is relevant. But hernia, ischemic heart disease is not relevant directly, but in order for operative fitness. Patient is always a known case, there is not a past history. Okay, past history is an episode which is a treatable condition like pulmonary tuberculosis. So tuberculosis is past history because the patient developed it, took the treatment, got well, fine, done. But known case is that since it was diagnosed, the patient would always have that diabetes mellitus. Secondly, when any of this is positive, then you want to talk about how long it is there, whether the patient is on any regular medication or not. Family history is similar. Menstrual and obstetric history, any female patient should feature in your history, right? Whether it's surgery, hernia, anything. Okay? Now, when whatever I have written here is something that is again, you just don't want to apply your brains, just speak this fluently so that your history goes on. Personal history. Don't say diet is mixed and sleep and so here also you can use this sentence. You can read that the patient takes mixed diet, sleep and appetite are adequate, and there are no disturbance of defecation and micturition. Your examiner may say that bowel and bladder habit, etc. When they ask you that how do you ascertain if the patient's bowel or bladder habits have changed, then what do you say? You say that I compared it with his earlier history. So I asked them that so the patient tells you that I go to pass stool twice a day. Then how do you arrive that whether it is normal or not? Then you always ask them that has it always been so? So the patient is so they don't say there are no addictions, say that the patient is a non-smoker, non-alcoholic and patient does not consume tobacco. Okay. Second part of today's session, abdominal exam. There are few things that I want to talk about here. Regions versus quadrant. Quadrants are simple to understand. Okay, quadrants are simple to understand. Just one vertical plane and one horizontal plane passing through umbilicus. Regions are also simple to understand. Two vertical planes and two horizontal planes passing through places. Two vertical planes are easy to remember. Everybody knows it. Midclavicular line, right? Now comes two horizontal planes. So those two are tricky to locate on surface anatomy because your examiner may ask you that you are telling me that this pain or the lump is in right hypochondrium, but in most patients if you see you cannot even palpate right hypochondrium if you truly draw it, right? It is almost beneath the costal margin. So if required you can maybe draw with a loose pen, pen or pencil and mark so that if you are describing a lump, you are very clear about what all regions is the lump going in. And it need not be in just one region, right? It can go like, so if it is right upper abdomen, it would most likely be right hypochondrium, it would be umbilicus, it would be epigastrium, and it would also be right lumbar. It is widely possible that it is these many regions. So let's talk about those two horizontal lines. The lower one, slightly easier to remember, is transtubercular plane. So what does it pass through? It passes through the iliac tubercle. How do you locate iliac tubercle? So you can, surface anatomy, you can easily locate ASIS, anterior superior iliac spine. What you do is you trace the iliac crest with your finger about 5 centimeter. If you go on the iliac crest, you reach the highest point, and that is iliac tubercle. Both iliac tubercle of a single line passes. That is your transtubercular plane. Transpyloric plane, you can call it lower margin of L1, passes through the tip of 9th costal cartilage. Difficult to identify. Like, how would you draw it on patient, right? Because you have not seen so many patients that you would be able to immediately palpate the tip of 9th costal cartilage. So what you do is you want to draw a line and find the midpoint. Okay. So consider that line is A and A to B. So you have two options. One line is from sternal notch to symphysis pubis. The right midway between these two is your transpyloric plane. The second option is lower end of sternum, which is also a root of xiphoid process, not the tip of xiphoid process, root xiphoid and umbilicus. If you go anywhere between the two, then that is also transtubercular plane. On inspection, always talk about contour of the abdomen. You know there are three contours. The contours are flat, scaphoid, and distended. Okay, flat, scaphoid, and distended. These are observed from the tangentially sideways. The second thing you would inspect is if all four quadrants are moving equally with respiration. In your cases, almost all of them will. Okay, see, when is that movement arrested? When there is inflammation going inside, when there is localized peritonitis. That kind of patient will not be there in your exam. Nonetheless, if the patient has giant splenomegaly, whereby you are already seeing a visible fullness on the abdomen. If it's a giant spleen, you can only see, you can already see before even you palpate even, right? So in those cases, you may feel that there is some change in the area where there is fullness. Umbilicus, you already know it should be, inverted or everted, horizontally stretched or transversely stretched. Fullness, as I just told you, scarce sinuses, and if there are any visible veins. Palpation, palpation of the abdomen, two things: superficial palpation, deep palpation. Superficial palpation is where you are assessing the container, and deep palpation is where you are assessing the content. So the content, if you have a case of abdominal lump, it means there is abdominal lump. Like if that case is in an exam, there is something to palpate there, right? Secondly, any patient with tenderness on the abdomen would usually not be kept in your exam. So usually your superficial palpation should be answered as, on superficial palpation, the abdomen is soft, non-tender in all four quadrants. On deep palpation, and then you can describe the lump. Now I'm not going in details of what lump, because abdomen is a it's a Pandora's box. There are many different kind of lumps possible, but you should, for exam, I believe you should prepare for splenomegaly, hepatomegaly, so right and left upper abdominal lumps. If you are asked that how do you palpate, so in a patient who does not have any tenderness, you can start with right lower abdomen, go clockwise. But if you know there is a lump, then you may do superficial palpation on all sides and then go from non-lump area to the lump area, so that you know that this is where it begins. On percussion, just so you know that flexor and pleximeter, the finger that you put on the patient is pleximeter, this is flexor. Movement should only be at the level of wrist. Normal note is tympanic all over the abdomen. On auscultation, the normal bowel sounds are low pitched, gurgling in character, and about 20 to 30 per minute. Okay, fine. Per abdominal examination, these are the basic things. Regarding specific lumps, I believe you can read for them. Long cases, I've taken few. The commonest one, inguinal hernia. age is important, younger is indirect, older is direct. I think you all by now understand the fundamental difference between a direct hernia and an indirect hernia. May I assume that? Am I right? Yes? Okay. Always say swelling in the groin. Okay. In the first history, don't say swelling in the inguinal region, say swelling in the groin. Uh, the history may be that it appears or it disappears on its own or it is reduced. You plenty of times you will find patients who will say that I can push it inside again. Pain. So when does pain occur in hernia? In the initial time of development, right? Because when the bowel is trying to get out of the abdominal cavity, there's pull on the mesentery, root mesentery, which is causing pain. But as the abdomen, as that bowel gets used to being pulled in the hernia, usually that pain disappears. That pain would be in the abdomen. It would not be on the hernia. It would be in the abdomen, and it would be dragging kind of pain, right? Acute pain complications, you know, it's irreducibility first stage, obstruction second stage, strangulation third stage. So what other histories would you ask for? So if you go through Love and Bailey, it says that increased abdominal pressure is only a probable cause of hernia. Okay, it is not the cause of hernia, but it reveals the hernia. So you would want to ask any episodes which cause increased abdominal pressure. So you remember 3 orifices. So patient may cough, patient may have trouble with urination, or patient may have trouble with defecation, and then accordingly you can ask all the symptoms. These are the ones that you are expecting. Now consider fever, unrelated symptom. So don't ask it. Fever, if you ask in case of hernia, now in a PG case, that person may be able to justify it one or the other way. But you don't want to go there, right? What's our aim? Our aim is to clear the exam, right? So inguinal hernia, now this is true, whatever I have written is true or rather recommended for any swelling. So when you describe a swelling, again don't go bullet wise. That the size of the swelling is 4 by 4 centimeters, the shape of the swelling is globular, the swelling is, no. It should begin with a single globular swelling of approximately 4 cross 4 centimeter is present in the right groin, extending from the pubic tubercle inframedially to mid part of the inguinal ligament, supramedially, normal overlying skin, and then the surface is smooth, etc., etc. But try to make it as a sentence. Okay, it shows the examiner that you know how to speak. It also talks about confidence. And then if at all your examiner wants to find something and ask you a couple of things, then he or she may ask you. So describe in a single sentence. Examination, you please, in long case, you have to say that I have taken consent, I have examined in adequate light, and I have examined in standing position. So for hernias, standing position. For varicose vein, standing position. Clear? For 2 things. So reducibility and impulse on cuffing. These 2 are cardinal signs of an uncomplicated hernia. Now these 2 you cannot miss. Okay, so when I'm talking about these 2, this is like literally passing level. So please know that if you are, it is also asked that tell me the 2 cardinal signs of any kind of hernia, uncomplicated hernia. Then you can say that it is reducibility and impulse on cuffing. So you must know, you must also be able to demonstrate a deep ring occlusion test. Deep ring is located about 2 to 2.5 centimeter above mid-inguinal point. What is mid-inguinal point? It is the point midway between the ASIS and pubic symphysis. What is midpoint of inguinal ligament? It is midpoint of inguinal ligament. So when you say the diagnosis, you have to include all the component in hernia. What side, inguinal or femoral, direct or indirect, incomplete or complete. So when you say direct, most direct hernias are inside the, whereas indirect can, right? So direct, if you are sure of, then usually it would never be complete hernia. Incomplete, reducible, uncomplicated, and whether omentocele or enterocele. And you must know that when you reduce it, if it makes, if it goes in easily initially, then that is more likely to be omentocele. Inguinal hernia, so they will ask for investigation. Now, for hernia investigation or for any other investigation, please remember this, that when you investigate a patient, you have two aims of investigating, two broad aims. The first aim is diagnosing. So, I am investigating so that I can diagnose. And the second thing is, I am investigating to identify the etiology of this diagnosis. Right? I'll give you the example as we go ahead. So in inguinal hernia or any even ventral abdominal hernia, the diagnosis is clinical. When I say clinical, it means that just by examination, you can keep a diagnosis. Right? So what are investigations for? They are for fitness for surgery. So if your examiner asks you that do you need any investigation for this patient? Then you may say for diagnosis, no. But for fitness for surgery, yes. Management is surgery. So get this thing very clear. Now some of you may be surprised that why am I stressing out in so much on this point, because I have been an examiner and I have heard plenty of things. So the management of any hernia is surgery. Clear? That surgery is hernioplasty. That surgery is hernioplasty. So there are very few examples where we do not use a prosthetic mesh now, a mesh now, right? By and large, the default is the mesh is always kept. How does the mesh work? So mesh causes foreign body reaction. It induces foreign body reaction, and that is why it causes fibrosis. That fibrosis then helps. The second case I want to talk about was breast lump. In your exam, by and large, if at all there is a case of breast lump, it would be malignancy of breast, by and large. Okay? Usually it would be so. Age is important, right? So, CA breast is so the way they may ask you is what's the importance of age in case of breast lump? And then you should be able to answer that younger the age, fibroadenoma, benign conditions, middle age and old age. CA breast is common. They may ask you the gender, what's the importance of gender? And you must know that out of all CA breast cases, it is 0.1% that are male gender. So when they ask you to justify your diagnosis in breast lump, that this is carcinoma of breast, that is one part. Obstetric and menstrual history are very important, right? So you must know that early menarche and late menopause. So the overall exposure of breast tissue to estrogen, if that period is longer, the higher are the chances of development of CA breast. Now pregnancy is a high progesterone status. So pregnancy is a break. So the more number of pregnancy, less total is estrogen. Clear so far? Okay. Medication, oral contraceptive pills, etc., and family history in mother and sister. Mother and sister, if they had anything like that. Examination is of course fully undressed up to the waist, 45 degrees to the cot, so that the breasts don't fall apart, fall so out that you are not able to palpate. Inspect for symmetry. I think examination points, your textbooks would talk better, but 2-3 things that a lot of students miss is do not forget describing the contralateral breast. One. Secondly, if you think that you are taking, this is a case of CA breast, I know, but I am not able to palpate the lump. That would be helped only if you palpate the other side, because you have not palpated so many clinical cases. So what's going to happen is when you palpate the contralateral breast, you will come to know that this is where the lump is, and then lump is to be described like any other lump. I mean, that goes, the description of swelling is site and size and fixity, etc. So palpate, in order to locate, palpate with palm, but in order to define the lump, palpate with fingers. So 3 structure fixity. So consider skin, breast tissue and P major, pectoralis major. So you have to talk about the lumps fixity to skin, breast tissue, and pectoralis major. Three things: skin, breast tissue, and pectoralis major, right? So skin, if it is infiltrated, if the lymphatics are infiltrated, body orange, you are expected to know. If you say that it is fixed or it is not fixed. If you say this, then your examiner will ask the patient that if you got the, compressing, if you ask the patient to compress on the waist and then you examined or not. Now, when you ask the patient to compress on the waist and you want to see the mobility of the breast lump, before that you have to ensure that the P major is taut or not. So how do you do that? So you palpate the anterior wall of the axilla, which is formed by pectoralis major. Always examine axilla and supraclavian fossa and abdomen. Okay. Now, there are things written in textbook. Usually we don't find abdomen hepatic metastasis and then palpable. It just does not happen in clinical practice. Triple assessment, you must know that history plus physical, USG plus mammography. Mammography BI-RAD categories you must know. BI-RAD 3B or 3A onwards, honestly, the patient requires biopsy. 1 and 2 are benign. 4 is almost certainly malignancy. 5 is clear-cut malignancy. FNAC plus biopsy. Biopsy is what kind? Core needle biopsy. Do not say true cut biopsy. True cut is a brand name. Core needle biopsy is the generic name. How many? 6 to 8 cores are taken usually, right? And they can be under ultrasound guidance. And for MET workup or metastasis workup, what do you require? You require ultrasound of abdomen and then X-ray chest and then X-rays of the spine, right? Management is two things. Usually your cases, if at all you have a case of CA breast, it would be stage 3A, 3B, probably it would be there, because if they keep a fungating mass, you already know the diagnosis. So they have to ensure that the skin is intact and it is a breast lump, so to speak. Modified radical mastectomy, you can say in most of your cases, which is okay. Breast conserving surgery, they may ask, but if at all they ask you that why breast conservative, like in which cases would you advise, then few pointers are that number one is that the patient would require rigorous follow-up. So you cannot have this patient operated for BCS and then lost to follow-up. No. If the patient is willing to come each time for follow-up, that is only when you would offer it. Otherwise, you better do what is conventionally advised. Thyroid cases, geography is important, needless to say. Calcium washout. It would usually be swelling. Now, thyroid, you will have two kind of patients, right? Either the patient would be euthyroid or the patient would be hyperthyroid, controlled hyperthyroid. Okay, primary hyperthyroidism and secondary hyperthyroidism. Primary is when both the things happen simultaneously. So the swelling also comes and the patient also gets hyperthyroid. That is primary. The secondary is swelling is there for long, 5 year, 10 year, 15 years, and now the patient develops hyperthyroidism. Few things in history do not say that the patient does not have dysphagia. Okay, thyroid swellings don't cause dysphagia. Dysphagia is difficulty in swallowing when there is something wrong with the oropharynx or the esophagus. What is happening though is that because it's a weighty swelling and with Berry's ligament, through Berry's ligament, it is attached to the larynx. And when you swallow, normally also, your entire larynx gets lifted up. It gets lifted up. So now, it was being lifted up all the time, but the normal weight of thyroid was 20 to 25 grams. But now the thyroid has enlarged 200 grams or 150 grams. So now the same larynx has to lift 150 grams. So it's more of a discomfort. Okay, so it's not true dysphagia. Dyspnea, they say that in tracheomalacia it can cause, but tracheomalacia in most cases would cause more of a trouble post-operatively rather than pre-operatively. Sudden pain in cases of if there is any degenerative changes in the thyroid or any bleeding. Endocrine dysfunction, you must know, right? Hyperthyroid, hypothyroid, and the hypo would be very subdued kind of patient. Hyperthyroidism would be irritability, tachycardia, there would be cardiac components, intolerance to hot environment, weight loss, etc. General examinations, skin, and then skin can be dry in cases of hypothyroidism. So when you inspect the standard questions that are asked is, why do you say that this is thyroid? So you can say that it's in the neck. It's probably, if at all it is a butterfly shaped swelling, then like that. And the cardinal thing is, when the patient swallows, it gets lifted up, which we just talked about. On inspection, they may ask what's Pizillo's method. So you say that in Pizillo's method, you just ask the patient to put the hands behind the, on the occiput and then lift the neck so that the thyroid becomes visible, especially the lower margin. When you palpate, you initially palpate from behind. Ask the patient to flex the neck a little, go behind the patient. Now, see, whenever it is something which is easily verifiable, your examiner can just ask the patient that, did this person go behind you and palpate you? Do you understand? So these things you have to broadly do. You just have to ask the patient to sit facing the other side and then palpate. Lahase is done from front, right? And that is where you just push on one side and palpate on the other side. You please do not miss bruit or thrill. Okay, you just so in cases of hyperthyroidism, severe cases, you can even feel the bruit or thrill. So you can just put your hand on the upper pole and you will easily be able you will easily feel it. If you don't feel it, it's okay. But if it is so loud that it can be palpated, forget about auscultation, and if you miss it, then that's not done. So now investigations, blood work is routine plus thyroid function test. Always remember that TSH is indirect measurement. So when you send for the levels of T3 and T4, the free ones are better because the bound one is bound to the protein, serum protein. So if serum protein levels are low, you will have erroneous results. Imaging USG is standard. There is also something known as thyroid score by Bethesda, which usually tells you about if there is a solitary thyroid nodule, whether it is taller than longer or not, what's the size, etc. USG will also tell you whether it is multinodular goiter or not. Now, a couple of things about investigation. So I told you one thing about investigation, that when you are asked in any patient about investigations, you have to see two things. First is investigations for diagnosis, and second is investigations for etiology. But when you are talking about investigation, so if someone asked you that what would you investigate this patient with, and if you say that I would send CBC for any case, I'm just telling you broadly. You also have to talk about what you are expecting to find when you send that CBC. So if you pause at just CBC, then I always say that there are only so many investigations. You can just say all the investigation, you would still be right. But that's not what the examiner is interested in knowing. What he's interested in knowing is, do you know the rationale of sending? So like consider you have a case of diabetic foot, and if you think that you want to send CBC, then why would you send it? Then you can say that I would want to see for leukocytosis, I want to see for hemoglobin levels, so that if that requires optimization. That is the kind of answer that your examiner wants, okay? Not just the label. And this is what is also expected in your theory paper. Clear? Okay, let's get back. So USG, so any swelling, surgery subject ni andar, when you see a swelling, you should think of two things: USG, that is imaging, and second is tissue diagnosis, which is FNAC or wherever applicable, biopsy. So USG guided FNAC, the limitation of FNAC is what? You cannot differentiate between carcinoma in situ and invasive CA, or follicular adenoma versus follicular carcinoma. Excess soft tissue neck sometimes helps laterally levama ave. It is taken from laterally, and it can help sometimes to identify early tracheomalacia before it causes problem postoperatively. What happens in tracheomalacia is because of calcium washout, the rings, the cartilages in the entire trachea have gone soft. Now, because the thyroid is attached, thyroid is attached like this. It is hitching it open. It's like it's hitching it open. But the moment the thyroid is removed, because it is soft, it collapses. Right? So a lot of times tracheomalacia would cause postoperative trouble. Anyways, solitary thyroid nodule, especially if hot nodule, we assume that 99% of the time it is the cause of hyperthyroidism. but cold nodules require further investigation like thyroid scan. Management. Now get this thing very clear now. Hyperthyroid patient, if the management is hyperthyroidism, so Graves, which is the commonest condition cause for hyperthyroidism, the management is you would get the patient euthyroid with treatment. How long will you keep the treatment? Maybe a year and a half, maybe 2 years, or if there are any side effects, right? Then you would offer surgery. Which surgery will we offer? Total thyroidectomy. Clear? Total thyroidectomy. Now that keeping 8 grams of thyroid and implanting it is not commonly done. What we do is total thyroidectomy followed by lifelong supplementation of thyroxine. This is already explained to the patient, right? So this is one. Now if there is solitary thyroid nodule on one side, okay, the patient has STN on one side and the patient is euthyroid. In those cases, we offer hemithyroidectomy. Why hemi? Because in thyroid, we do not do biopsies. And FNAC only can provide you with some value, not more than that. Then what do? You remove one part, send it for biopsy. Okay, peripheral arterial diseases. This is your another long case. So, standard questions are intermittent claudication. How does it differ from routine pain, right? So intermittent claudication would happen in muscles. It is because of muscle ischemia, and IC would happen slightly distal to the block. So if the block is somewhere in profunda femoris or superficial femoral artery, then IC would happen in calf muscles. But if the block is in popliteal artery, then IC would happen even below, maybe calf and foot both. Boyd's classification, everybody knows, 4 grades. 4th grade is rest pain. Always remember, how do you differentiate? How do you say that it is rest pain? Rest pain is ischemic nerves. So it is no more inflammatory pain. It is ischemic pain, right? It is ischemia because those nerves are no more getting any blood. So it is ischemic pain, and that is why it is relentless, and no matter what you give, it just does not help the patient. So the question you ask is, can you sleep at night? So if the patient says that no, I cannot sleep, you already know. Now if you have a case of PVD in your exam, you already see the patient sitting by the side of the cot with his foot hanging, most likely the patient would already have rest pain. Okay, so this is to give you an idea that then you already know that this is an advanced disease, and then you can say this to your examiner that the patient prefers to sit by keeping his feet hanging by the side of the cot. If there is any ulcer or gangrene, ulcer are to be described the way you describe ulcer, and what to speak I'll tell you. Gangrene, dry gangrene and wet gangrene. Dry gangrene happens in cases of acute obstruction. Acute arterial obstruction has 5 P's. Everybody knows those 5 P's? Pallor, pulseless, paresthesia, paralysis, and loss of function. Pain, 5th P is pain. Boyd's classification I just told you. So in history, apart from pain and ulcer, now what negative history? I talked about negative history in other cases. How would you ask for which other question should you ask for? So if there is ischemia in the lower limb, think about ischemia at other arterial places, or consider other arteries also involved. So if you would see cardiac arteries involvement, coronary artery, then you need to ask for chest pain or breathlessness. If there is cerebral artery, so carotid involvement, you can ask for history of TIAs, or if there are any visual blackouts, any history of stroke earlier. If there is GI arterial involvement, supramesenteric artery involvement, etc., then the patient would have postprandial pain. Now this is not very common. So SMA thrombosis is very common. We see that regularly. But PVD nu patient, and if you go and ask him, though, I'm not sure if he would be able to give you an accurate answer, which would then tell you that this is postprandial pain. You need to examine, ask for similar complaints in other limbs, including both upper limb. And if there is any past history of family history, similar one. And here the past history of ischemic heart disease, even diabetes mellitus, hypertension all become very important. So signs of ischemia, these are common things. So overall the limb would appear thinner, right? Now think that all the integuments of the skin have stopped receiving blood supply because skin is disposable, right? I mean, if the body has to choose whether to continue giving blood to the muscle or to the skin, it would of course continue to give blood to the muscle. So skin integuments will suffer. So skin integuments are sebaceous cysts. So when they go off, the skin becomes dry. There are hair follicles. When they go off, there is loss of hair, right? When the nails stop receiving blood supply, they get brittle, dry, and deformed. So this is how you remember that these are the things that you have to see. Overall reduced girth, then there may be even minor ulcerations apart from the major one. If there is ulcer or gangrene, you have to describe that. But these are standard theory questions, but I think lower limb, all four arteries, that is femoral, popliteal, dorsal spidis, and posterior tibial, so DPA and PTA, these four arteries you must know how to palpate. And if you cannot palpate popliteal, it is okay. So don't bluff. Okay, so if you think you have not palpated popliteal, then don't bluff, because it's sometimes difficult for us also to palpate popliteal. But for the rest of it, I think if you just, even if you palpate each other's arteries, you will be able to know, okay, this is DPA exactly aaj gaya hai, and I think it's very simple to do. But in case of PVD, you also need to palpate carotids, you also need to palpate upper limb arteries, and you also need to speak about it. Okay. Other tests are, you need to auscultate for bruit, because at bifurcation there can be bruit. Berger's postural test, all these tests in PVD and in varicose vein, they are usually of historical importance only. Okay, we usually don't do these tests. So Berger's test, where you elevate the limb and then see at what angle the limb totally gets guttered and gets pale. It's not routinely done because in most complexions it would be very difficult to identify, and plus it does not provide you with any meaningful interpretation to manage the patient. Capillary filling time, and then nail bed blanching, etc. These are also to be done, and you need to see. So now comes investigations. Again, I told you two prongs. One is for diagnosis and the second is to identify the etiology. So blood work, CBC, you want to see if there is any leukocytosis, you want to see what the lipid profile is like, if the patient is diabetic, and if it is, then what's the status, if there is any patient has any prothrombotic conditions, right, protein C or S deficiencies. ABPI is a part of investigation. Ankle brachial pressure index 0.9 to 1.3 is normal. Anything less than 0.9 is some amount of ischemia. Imaging is duplex ultrasound. So duplex ultrasound is different than routine ultrasound in terms of it has B mode ultrasound, and then there is another ultrasound, or two ultrasounds are used. So first one would image and the second one would, so to speak, color it, so that the blood flow that is going towards it and going away from it, they would color it blue and red. So duplex ultrasound is your primary investigation. If there is any major block is expected, then what do we do? Then CT angiography is advised. CT angiography would also talk about distal runoff, and it is very good in imaging aortoiliac block and all thoracic arteries, because thorax you cannot image with ultrasound. There is bone, so you cannot image thorax with ultrasound. General optimization, hemoglobin and protein, comorbidity, whichever are there, really strict monitoring and control of them. Stop smoking should hit the, like તમને જેવું પૂછે PVD ના patient માં કે what is the management, the first thing you should say is stop smoking. So it's part of management. So do not just assume that my examiner already knows that of course smoking stop. No, you have to say it. Drugs usually used are pentoxifylline, cilostazol, rivaroxaban recently. If it is acute obstruction, then we would heparinize so as to thrombolyze. And finally, procedures. So the same procedures that are done for heart. So if somebody has a angina or ischemic heart disease, we do PTCA and we do bypass. So those two things are also done, but they are done for major blocks because you need some diameter of the artery in order for you to perform surgery, right? Varicose vein, importance is that of profession, pain which is usually in calf, usually in the evening. This is important, and some examiner may ask you that is it really pain? So then you can say that, sir, it's not actually pain, but it can be uh, called as heaviness, fullness, engorgement, etc. Right? Itching and ulcer. So in varicose vein, there can be three symptoms. So one is visible veins, second is visible veins, then itching, which is eczema, and third is ulcer. Past history of DVT, drugs, or any prothrombotic state, which are physiological prothrombotic states in human body. Pregnancy is one, right? So after pregnancy, venous thrombosis is common. So I should not say that all pregnant women develop this, but it is one of the cause. So examination, again, as I told you, standing, and you have to say that I examined this patient in standing position. You don't assume it. Medially, you would of course know the root of great saphenous vein, just behind the medial malleolus, medial side of the leg and thigh, and enters 2 to 2.5 centimeter below and lateral to the tubercle, which is the opening of saphenofemoral junction. Now, when you palpate that vein, there are times when you will be able to palpate the incompetent perforator in terms of dips. You will only be able to palpate it. I cannot describe them. But if there is a vein, and if you palpate along its course, you will be able to palpate as if gaps or dips. Other things that are done is, now there are plenty of tests described in ESDAS and other clinical books. Almost none of them are done, including tourniquet test. But we will still talk about it. So percussion retrograde. What is retrograde in lower limb? Proximal to distal. Normal is distal to proximal. So retrograde in lower limb is proximal to distal. So when the patient is lying, the vein is full. If you tap on one side, if it travels, if that wave travels, that is known as percussion wave. You want to see for skin around the ankle. Now, common questions are, what is Gator's area? It is at the medial malleolus, right? You also read about what is Gator. What actually is Gator? Read about it. Gator's area, why is it the commonest place for ulcer development? Because it is the point of maximum ambulatory venous hypertension. So when someone is walking, someone is standing, it is that place where the entire column of blood is resting. So you can imagine that it is like literally holding a lot of weight on it, right? So that is why those veins, they start giving up capillaries. And when they start giving up, they tear. The RBCs then go in subcutaneous tissue. They are destroyed. Hemosiderin is released. That causes local inflammation, which then causes eczema, eventually ulcer. So Brody-Trendelenburg test, when you will ask the patient to lie down or empty all the veins by palpating, and once you do that, you occlude the saphenofemoral junction, ask the patient to stand up and see if it fills immediately or if it takes time, and if you release it, whether it fills immediately or not. Perthes is when you apply tourniquet at multiple places and ask the patient to walk. What is happening is that whatever remaining blood was there between the two tourniquets, so there's a vein and two tourniquets are there, so whatever remaining blood is there should get sucked up in the deep venous system, if the deep venous system is working. So Perthes test is for competence of deep venous system. These are the questions that your examiner may ask you, but honestly none of these tests are done. Tourniquet, obsolete in clinical practice, but usually two are applied, like upper thigh, mid thigh, lower thigh, and 3 in the leg, right above the ankle, and 1 in mid leg and upper leg. How do you apply, if at all you are asked? So take a catheter, apply it, and then maybe you can occlude with a artery forceps. Okay. Fine. Again, duplex and other relevant investigation for prothrombotic state. What is management? So management is manage the vein, manage the eczema or ulcer, whatever is there in patient. So the management of varicose vein is, if the large trunk is involved, main trunk, saphenofemoral junction to incompetence, or to removal of the vein, which is saphenectomy, also known as varicose vein stripping, that is done. Okay. If it is only perforators, so the main trunk is not gone, only perforators are gone, then you may try sclerotherapy, injection sclerotherapy, but that has to be done under USG guidance. What are the complications of sclerotherapy? Deep venous thrombosis, right? And secondly, any management of superficial varicose vein, which means affection of superficial system, requires that you have intact deep venous system. Right? So the only contraindication to removing the superficial vein is when there is deep venous thrombosis, because that system is not working, this one is working partially, and if you remove this one also, the patient will develop venous gangrene. Typical question is, how would you manage the venous ulcer? Which kind of dressing is done on venous ulcer? Saline dressing. Okay, what you should say is saline dressing. Few short cases, then we'll call it a day. Sebaceous cyst, dermoid cyst, you all know standard thing. A sebaceous cyst, it would have a punctum. Management is removal. You can still get done a FNSE. Can happen at almost all places wherever there are sebaceous glands. Dermoid cysts are where congenitally two segments are joining. That is where they can happen. They can be there. Common ones are post-auricular, near the eye, lateral angle of the eye, etc. Again, the management is removal under anesthesia. Lipomas are very common, can happen everywhere. Then they may ask you that do you need to remove all the lipomas? Then you can say that it's not urgency, but if it is at a place where it is hurting the patient, consider somebody has a lipoma in the axilla or in the medial side of the thigh where it keeps on rubbing against the. So then I would offer what is multiple lipomatosis. Numerous lipomas all over the body. Do they all require removal? No, they don't. Ulcer. So you want to remember that common causes of ulcer, when you're asked, then it can be diabetic, it can be infective and traumatic. These three are very common causes of lower limb ulcer, foot ulcer, which you will have a case of. Whenever you have a case of ulcer, please know that basic definitions like what is granulation tissue, you are expected to know. What is slough, you are expected to know. Like if you do not know them, then there is problem, right? So if your examiner is asking you these basic definitions, that means that you probably are not doing well. Do you get it? Because now he had to come to the most foundational things that चलने तू at least आटलू बोली जा तो, right? So okay, so let me get back. So ulcer, you must know how to describe it. Again, a single ulcer of 4 cross 4 centimeter size is present on the dorsum of right feet, which is approximately 2 centimeters from the root of the great toe and about 3 centimeters from the medial malleolus, something of that sort. So try to make a single sentence. And then once the examiner has an idea of where the ulcer is, then you start from laterally. What the margin is like, what the edge is like, and what the floor is like, what the ulcer is resting on. And then if at all, now see, if you think that there's a dressing lying right besides the patient, the dressing was done in the morning and it's lying right besides the patient, the dressing is drenched in pus, right? So you should have noticed it. You don't need to clean it. But then it should form that, then you cannot say that there is no discharge. It's already right there. And if you want to say that there is no discharge, then get rid of that thing. Right? Clear? I mean, common sense, right? This is nothing, no rocket science here, right? So common definitions, enterostomy, ileostomy and colostomy are also common cases. I mean, standard textbook stuff. How would you differentiate through the effluent? The first thing you say is through the site. How would you differentiate between ileostomy and colostomy? The first thing you say is site. Okay? The way you talk about site, the first thing in ulcer and inswelling, the same way here also, that's what you do. Okay? Then indications, etc. are theoretical questions, but examination. When you examine it, what you have to see is the condition of the bowel. So what would you say? The bowel is pink. There is no edema. Bowel is pink. There is no edema. There is no prolapse also. If there is no. And there is no retraction also. So the bowel is pink. There is no edema. There is no prolapse, no retraction. and then it is well functioning. So if you already are seeing some effluent in the bag, it's well functioning, right? So this examination part is important. Then you need to talk about the surrounding skin. If it has been kept totally open, you will be able to see. If it has not been kept totally open, and if you asked and somebody said no, we couldn't get the bag, and yesterday only we have gotten a bag, we don't want to remove it. So then don't talk about the skin. Then if you have not seen, then don't say. Okay. Okay. Usually when is ileostomy or colostomy is closed? 6 weeks, 1.5 months. Why that much time? So that the primary pathology is under control, the patient is doing well, and peritonitis has been taken care of. But can we go longer than that? Yes. Can we go shorter than that? Preferably no. Okay. And before that, what do we get done? Before you close, what investigations will you get done? Loopogram. There is something known as loopogram. So what you would do is you would inject some dye in the distal loop and see if it traverses all the way up to the rectum or not. So that I know that, okay, distal passage is okay, there's no more leakage. Because otherwise what will happen is I'll close this and then I come to know that the patient has leakage, he'll end up in another ileostomy. Amputation stump, you must know all the levels, few names. What are the characteristics of good stump versus bad stump, etc. Oral cavity exam, just points તમે જોઈ લેજો. Sometimes some examiner may ask. And now finally some generic advice that do not speak what you cannot justify. In any swelling, when you say globular, make sure that both dimensions are same. So you cannot say a globular swelling of 2 by 4 centimeter in size because that's already oval. You just said so, right? And always charge your laptop at the time of presentations. Do not lie in the exam, I told you. If the patient, you have taken the temperature at the back of your hand, then just say the patient is afebrile by palpation. Simple. Do not forget external genitalia examine, at least speaking about external genitalia. And trust me, male patients always see that both testes are descended, whatever is your case. Okay? So if you have a case of varicose vein, you have not examined the external genitalia. Now what happens if the examiner asks you, okay, let me examine. He undresses the patient and one testis is missing. So you cannot justify that. It means you did not see. Do you understand? We are surgery. A lot of anatomical things, present or absent. This is not like tachycardia. Oh, at that time there was tachycardia, but now it is not there. Do you understand? So anatomical things you cannot miss. You cannot miss a scar on the abdomen. That's a major error. Okay. Okay, finally, any swelling consistency is very important. Do not do transillumination if you already are saying that the swelling is cystic. Transillumination is done to differentiate between what? Whether the content of the fluid are transparent or they are not. So you have three consistencies, right? Cystic and solid. The solid can be soft, firm and hard. But now it is cystic consistency, then only you will be able to do transillumination. So you cannot say that it was a hard swelling and I did transillumination there. And always know the length of your index finger. તમને short cases ની અંદર બહુ જ કામ લાગશે. Because તમારી પાસે time નહીં હોય. અત્યારે બેઠા છો એટલે લાગે છે. At that time you will be under huge stress. So at least you will be able to say roughly that this swelling I measured and it's approximately 3 cross 4 centimeters. Okay. Some of you can please scan this and give me feedback on the session. Please, फटाफट. તરત જ મેં માંગી લીધું છે પણ I had no option. Okay, some of you may scan. If all of you do it, that's great, and you may share that with if somebody has forgotten. Okay, thank you. કિરીટ ભાઈ આવી ગઈ.
Hello. તમારામાંથી કોઈએ if you already gone through the X-ray instrument, so anybody are like that they don't want to do second time because already it has been recorded, so I should not speak. If you have gone through, then it's fine. If you are new and you have not gone through the X-ray instrument specimen, then only I will continue. So you want to continue or should I call it off? Okay. So in the tables, બારણું બંધ કર દે. શું છે યોગેશભાઈ? X-ray instrument and specimen. Whenever in surgery exams, your long case, short case, and all are gone. So you are already drained out, and then you are appearing for this. No. The worst part is that majority of you, I regret to say, that don't come to the OTs regularly, neither emergency, neither planned. So you don't have already seen any procedures. When we asked 4 or 5 questions, we came to know that you are all novice, and the worst part is that people have not even seen on YouTube also. I asked them that, okay, hernia surgery you have not seen, I am fine, but you have not seen even in YouTube also. That you should have that curiosity to learn the things, right? Okay, nonetheless, because I am going to take lecture, commonly asked questions, I will not take much time, we'll go, because it takes a lot of time to learn these things, right? But તમારે exam છે, exam ના આગલા દિવસે આપણે practical tips, how they are going to ask you and how you should answer. Commonly asked questions and commonly how not to make a blunder, right? So instrument, these are the things that is commonly going to be asked. Identify the instrument, describe the parts of instrument, what material it is made up of. These are the very commonly asked questions, right? Please describe the use of the given instrument, where you will use and how you will use. Specific procedure may be asked. Suppose there is a cord holding forceps, so an examiner might ask you most of the times hernia, that what type of hernia surgeries and what you have seen, rather what should be done. Commonly asked surgeries, hernioplasty, what is hernioplasty, what is open, what is laparoscopy, right? So these are the commonly asked questions when you go for on an instrument table, X-ray instrument and specimen table, right? Then point comes, what is sterilization? How will you use this instrument? Suppose table ઉપર પડ્યા છે બધા instrument, examiner will ask, will you use this instrument directly into the OT or you will do something else? So then you will say that I have to sterilize the instrument. So what is sterilization? Commonly asked questions, everybody must know what is sterilization, what is autoclaving, the basics of all, right? So sterilization, the most important thing that you should speak is the spores. The spores has to be killed. If you don't kill, what will happen? There are chances of gas gangrene, tetanus, all that. So the best is all instrument has to be sterilized. then there is disinfection. How will you disinfect the things? So both are the same, but here you cannot kill the spores. And there are some antiseptic solutions. What is antisepsis? What is disinfection? And what is sterilization? These are the three commonly asked questions. Barabar? These are the different methods. Physical and chemical methods. Again, physical. So this is the basic theory, right? Examiner wants to ask you what is the best method of sterilization. You have to ask two things you must know. One is whether the instruments are sharp or not. If they are sharp, you can say that you can do two things. Chemical sterilization, best is gas sterilization, that is ethylene trioxide gas. The best of all is autoclaving. So what is autoclaving? So when you do autoclaving, the three things that your examiner would ask: what temperature, what pressure, and how much time. All the autoclaved instrument has to be sent to the in the OT trolley pre-operatively, right? And these are transferred from, if you are in a big hospital, most of the times we all are working in a hospital, big hospital, there is one CSSD department, right? So what is that? Nothing but the sterilized equipments they are done in mass sterilized, and then they are transferred to the operation theater in a manner that there should not be any infection, right? So from the CSSC department it will go to the OT by doing autoclaving. What is autoclaving? What is the principle of autoclaving? The principle of autoclaving is heat under pressure, or what we call it moist heat. What do you mean by under pressure? Under pressure means same temperature, 121 degree temperature, you keep it for say 1 hour. Why you want to buy an autoclave? ગરમ પાણીના તપેલામાં નાખી દો અને 2 કલાક ઉકાળો. The difference here is that you want to kill the spores, number one. Number two, in autoclaving it is under pressure, so that there is a latent heat of evaporation that gives rise to killing of all the spores, all the microorganisms. So that's why autoclaving is very important, and you all must know what is autoclaving, what temperature, pressure, and what time you will do autoclaving. Most of the instruments you can do autoclaving, right? Only sharp instruments and tubes are not sterilized by autoclaving. They are sterilized by ethylene trioxide gas most of the times, right? Plastic tubes, say intercostal drainage tube, intra-abdominal drainage tubes, Ryle's tube, Foley's catheter, whatever we commonly used, that is tracheostomy tube, everything is pre-sterilized available by the ethylene oxide gas. So you don't need to sterilize in your OT. Only thing that you need to sterilize is a specialized equipment. Suppose nowadays autoclavable scopes are available, either endoscope or laparoscope. The telescope, laparoscope, everything, laparoscopic instrument, all can be sterilized in ETO gas. ETO machines are available. You put it there inside and then you use. Suppose we are doing a laparoscopic hernia, we use takers to fix the mesh. Now one taker might be containing 18 to 20 clips. So you apply 2, 3, 4 clips, and then what you do? That is very costly, right? So you again put it, you do ETO, and then you can reuse in the second patient. Laparoscope, endoscope, all you can do ETO, right? Or they are also autoclavable scopes are also available. So most important thing is that which instrument not to be sterilized by autoclaving, that is sharp instruments. What material it is made up of? તમે stainless steel બોલો, that will be fine. આ બધી જ different metals are available, tungsten coated, scissors, tungsten coated, instruments, needle holders, everything is available. That are the latest, right? So that you can do better. Then in surgical instruments, two things are asked about laparoscopic and endoscopic instrument, that I already told you. That the parts of different laparoscopic instruments and endoscopic instruments UG exam માં મોટે ભાગે નથી પૂછતા કે નથી મૂકતા, કારણ કે they are very costly. મૂકે કદાચ ટેલિસ્કોપ ઓલ્સો ઇઝ વેરી કોસ્ટલી. મૂકે તો કદાચ હેન્ડ ઇન્સ્ટ્રુમેન્ટ મૂકે લેપ્રોસ્કોપીના, રાઈટ? તો તમને હેન્ડ ઇન્સ્ટ્રુમેન્ટ શું છે તમને ખ્યાલ હોવી જોઈએ. જસ્ટ મેં એક લિસ્ટ મૂક્યું છે કે અને લેટેસ્ટ એનર્જી સોર્સ, that is also part of theory, total theory that you should learn, that what in surgical instruments the most important in armamentarium of a surgeon is latest energy sources like electrocautery and whatnot. Everything has came up in a very big way. Then there are parts of instrument. The most important is in instrument is the what part is there. So these are the parts. It starts with when you hold the instrument, you have to hold like this. One, your ring finger goes into the one finger bow, another thumb goes into the second finger bow, then your second finger is going to stabilize the instrument. Suppose I am holding a needle holder, so this is going to stabilize and my index finger is going to guide in which direction I am going to use the instrument. So it starts from the finger bows, ratchets or catches, then the shank or shaft of the instrument, then there is a joint, then there is a blades, and then there is a tip. So here in this you can see either handles or for the rings, right? Ratchets, shanks. Shanks means this part. I think I cannot show you. Jaws and tips. The important part in this instrument is the joint. There are three types of joint. One is box type of joint, second is screw joint, and a third is spring type joints. The joint, the box type of joint is such a that it gives stability to the instrument. From that one instrument, the another part of the half part of the instrument is gone through. That is why it is a box joint. It gives more stability. The scissors usually have a screw joint. So you open up the screw, then scissor both the ends will open. There is screw joint, and in the forceps there is a spring type. There is spring type action. So there are three types of joints. So in exam, if examiner asks you identify the instrument, then you identify. If whatever examiner asks, you have to speak. What are the parts of instrument commonly asked? Then you have to see 1, 2, 3, 4, 5. Right. Now there are types of instrument. There are how many types? Different types of instrument. First is grasping and holding instrument. That is sponge holding or towel clips. Then there are n number of names of each and every instrument. It's sometimes, most of the times, difficult to identify. Why it is difficult? Because it is not commonly seen by you to be being used. Sponge holding forceps, if you say, that's fine, but Rampley's sponge holding forceps, if you say, that's well and good. That is needed. See why I am telling this. Suppose I am using a scissor, then there are different types of scissors. Mayo's scissors, they are being given the names of that scientists. Mayo's scissors, Madsen-Bohm scissors. Now these are the two, and third is Potts scissor, but that is PG level question. That is used to open up the either vessel or used to open up the common bile duct. CBD opening માટે સ્પેસિફિક યુઝ થાય. ઇમ્પોર્ટન્ટ બે છે, મેયોઝ અને મેડ્સેન-બોમ. પણ એ તમને ના ખ્યાલ હોય તો મેયોઝ સીઝર ઇઝ યુઝ્યુઅલી ફોર ધ સુચર કટિંગ, એન્ડ the Madsen-Bohm or Matt scissors, Mads that we in short form આપણે કહીએ, it is for the tissue cutting. If you want to open up the peritoneum, if you open up the bowel, any tissue if you want to open up, these scissors are not that sturdy. These are fine scissors. And again, these kind of scissors, that's why two names. So if you have to remember the names, it is better that you remember, because but if you know the function, then examiner is fine at UG level. તમે એમ કહો કે સર આ suture cutting scissor છે કારણ કે જાડી છે ને એના, so that is fine. So you should know the different types of scissors. Then comes the cutting and dissecting instrument. Again જે આપણે discuss કર્યું કે first is needle hold, knife handle. Knife handle બે ટાઈપના તમારે યાદ રાખવાના, 3 નંબર ને 4 નંબર. 3 નંબર is for the smaller knife to hold, 4 number is for the bigger knife. Bigger knife is 23, 22. These are the for the laparotomy. If you want to use a laparotomy, these are the knife handles that you use, right? Knife itself and knife handle. The knife no number hoy 11 or 15 number are small. 11 is used for incision and drainage. IND માટે stab knife આપણે જે કહીએ ને stab knife, that is 11 number, and 15 number is a plastic knife, that is for the smaller surgeries when you do excision biopsy and all that. For the area, suppose head and neck, suppose you are doing any area where you need to do cosmesis and smaller areas, you are always have to use that 15 number knife. Then different type of retractors. The last thing, needles, knives and sutures. Sutures are with the needles. So તમને exam માં sutures, if it is asked that if you are being asked about the Foley's catheter, if you are asked about the Ryle's tube, drain, any tube, most of the times તમને આખું જ આપે. It is being given with the wrapper, and in all the wrapper everything is written. The most common is within the sutures. Sutures ni under two things you have to: what type of suture material it is, what type of needle it is, what the length of the suture material, everything is given in that. એટલે તમે ખાલી અને એક્ઝામિનર એવું નથી કહેતા કે તમે જુઓ નહીં, તમે જોયા વગર એન્ડોટ્રેકલ ટ્યુબ છે ને સર ધીસ ઇઝ રાઇલ્સ ટ્યુબ, એમ વેરી ગુડ, ચલો હવે પછી પૂછે પછી જાત જાતનું. સો ઇટ્સ લાઈક દેટ ઇફ યુ આર બીન ગિવન એનીથિંગ વિથ રેપર, પ્લીઝ રીડ ઇટ. કોઈ સોલ્યુશન પૂછ્યું તમને તો એવરીથિંગ ઇઝ રિટન ઓન દેટ સોલ્યુશન, અનલેસ ઇટ ઇઝ કોઈ ડબ્બીમાં કાઢીને તમને મૂક્યું હોય બોટલમાં, ધેન ઇટ્સ ફાઇન. પણ ઇફ ધ સોલ્યુશન ઇઝ મોસ્ટ ઓફ ધ ટાઈમ્સ બોટલ જ મૂકી હોય ને બોટલ ઇન્જેક્શન હોય તો એનું નામ સાથે મૂક્યું હોય, then you please go through and read it. Suppose it is Foley's catheter, everything is written, what number, what is the size of the, that you can inflate the balloon, how much ml you can inflate, everything is written very nicely. But you don't bother to see it. That is the biggest problem, right? Okay. This is swab holding forceps. Where will you use? So we start from here. Patient has been taken into the OT, patient anesthesia has been given, patient is supine. The first thing that you will do is prepare the patient, painting and draping, right? But whenever swab holding forceps is kept, student will say, sir, painting and draping is done with this. No, painting only. Difference between painting and draping is you paint the area with betadine, commonly used name, barabar. It is povidone iodine. So in exam, if at all, if examiner asks what you use, it is polyvinyl pyrrolidone or povidone iodine. Povidone iodine is applied and then you apply the spirit, so that you are doing painting of that area. What is draping? Draping is nothing but the sterile towels you are applying to isolate the area, operative area. Suppose you are doing a laparotomy, you are doing a thyroid surgery, so you want to drape the area properly. So that sterile towels are kept there. So painting and draping. So no, don't speak whenever sponge holding forceps is there, don't say that it is painting and draping. It is painting only, number one. What are the other uses? Commonly asked questions. Whenever this is the sponge holding forceps is there, commonly asked question are, commonly asked surgery is open cholecystectomy. This is straight. This is straight forceps, right? The handles are straight. Then there is curved also. That curved is used to do open cholecystectomy. When we convert, during open cholecystectomy, we hold the neck of the gallbladder and we hold the fundus of the gallbladder. Two things we hold, and then we start dissecting at the Calot's triangle. And we have to dissect what? Cystic artery and duct. In exam, lap chole or open chole, what you have to say, which you will tie first? Always you have to tie first the artery. કારણ કે તમે ડક્ટ બાંધી કટ કરી, artery is very friable, it can bleed. So first and foremost, always try to dissect and tie or ligate or clip the cystic artery, then the cystic duct. So that is commonly asked questions. Laparoscopic cholecystectomy is gold standard treatment option for gallstones. Symptomatic gallstone, cholecystectomy you are doing, then laparoscopic surgery is gold standard. Cholecystectomy. Laparoscopic appendicectomy is gold standard. For hiatus hernia, laparoscopic hiatus hernia repair is also considered as a gold standard. So examiner asks you which is the gold standard, whether you go for open or lap, you will go for lap, right? Then the towel clips. You apply towel clips so that the painting, the draping done by you, the sterile towels will stay there, so that the surrounding area there should not be any contamination in the operative field. Tooth forceps, commonly asked questions, where you will use, what it is. So what you have to see is whether it's a tooth forceps or it is a toothless forceps. So you have to see in detail whether which type of forceps it is. Tooth forceps is used, there are teeth, so that you can hold the tough structures like fascia. But once, suppose you are doing laparotomy, once the peritoneum is opened, you have to put aside the tooth forceps. You have to use toothless forceps only, so that you don't injure the bowel, you don't injure any important structure. The important thing is that this is a spring type of action. So here the fulcrum base, the instrument examiner might ask you what is fulcrum and work to be done. So physics principle, as the fulcrum shifts away, the force applied or force needed is very less. When the fulcrum shifts towards you, you will require more force. So in these forceps, you will require more force to get the work done, because fulcrum is towards you. Fulcrum goes away, the fulcrum list is in needle holder, because in needle holder the fulcrum is away. The handles and blades are very small, handles are longer, shanks are longer and blades are smaller, right? Because you need to go through the tougher tissue to take the sutures. So you should require less force to get the work done. So that's why the fulcrum is away. That's why the needle holders are more tougher, more stouter instruments than the artery forceps or hemostatic forceps, right? So this is the basic on which it works, both the same things. Edson tooth forceps, these are usually used in plastic surgery or usually used when you are doing near the vascular pedicles, so that they are very sharp pointed and you don't end up injuring it. Mosquito forceps. So the commonest problem with this is people say that, sir, this is artery forceps first and foremost. So examiner asks, why not venous forceps? So better to speak it as a hemostatic forceps. Why hemostasis? What is the function? What you do is you do it for the hemostasis. તમને vessel હોય, bleeding હોય, you want to hold the vessel. Number one, you want to hold the important structures. You can hold it, peritoneum you can hold with this, or any fine structures you can hold with this, right? So why it is called as mosquito forceps? Someone say it's a very smaller instrument, usually used in surgery, in circumcision surgery, right? And this mosquito forceps is, somebody says it looks like mosquito, but after the World War II, it was like the shape of a mosquito bomber. So that's why it is called as mosquito forceps. Two forceps important is Ellis and Babcock's. These two forceps are tissue holding forceps. Ellis is traumatic and Babcock is atraumatic. Ellis tissue holding forceps is used where? Used to do the tough structures, to hold the tough structures like fascia. You can use to hold the ligaments, tendons, everything you can hold with the Ellis tissue forceps. Otherwise, you can hold the important structures like long tubular structures like appendix, fallopian tubes, ureter, small bowel, everything you can hold with the Babcock's forceps. So whenever Babcock's forceps aave tamare, so examiner might ask you that where you will use. So better please speak appendix first. If you speak fallopian tube first, a surgeon would not like. Gynec ની exam માં પહેલા એ બોલવાનું, surgery ની exam માં પહેલા appendix બોલવાનું. Long tubular structures to be held with the Babcock's forceps. The use is that. One another use when other instrument is not available, like cord holding forceps, you can use in open inguinal hernia surgery, where you can hold the cord structures with this, with the help of Babcock's forceps. Already discussed about the needle holder, right? So I am not going in detail. The only thing that I wanted to tell is how to differentiate needle holder from the hemostatic forceps. So first and foremost, it is stout instrument, right? The fulcrum is away. See the smaller one, the need. This is the smallest one. આગળની જે handle છે એ આગળનો એકદમ small હોય because and it is having criss-cross serrations. These serrations are there to hold the needle, and it requires tough structures. And whenever examiner asks that how will you use it, so that the movement should be at the wrist joint, at the elbow joint, not the wrist joint, at the elbow joint. So you enter the needle at the 90-degree to the tissue and then try to just hold like this. So it is the movement that occurs at the elbow joint, not the wrist joint, right? So that this is all why you want to do everything is just because we want to look for that minimum amount surgeon એટલો થાકી ના જાય, right? So that the less amount of force is required to get the maximum work done. And suturing આપણે સર્જરીની છેલ્લે હોય 4-5-6 કલાક સર્જરી ચાલ્યા પછી વિપલ્સ કર્યું હોય તો after 5 hours you are suturing, right? Then તમે બધા થાકી ગયા હોય. Then the senior first year or second year is suturing everything. So it is better that the way you should be suturing an exam માં ખાસ એટલું examiner ને it has to be at the elbow joint, not at the wrist joint. Backbox we have discussed. Scissors, these are the Metzenbaum scissors. These are the small scissors, the delicate scissors. There are two types, curved and straight. Whenever the area is small, you have a curved scissors. This is Mayo scissor. Mayo scissor are suture cutting scissors. Let's stout scissors hoy, jadi hoy, to cut the sutures. Now comes the retractors. Retractor, only thing is the examiner will ask that what is the name of the retractor. So this retractor is very famously asked. So એટલું યાદ રાખવાનું, lever for lever. This is lever's retractor for lever. And how to use retractor? The basic principle is towards sky. The retraction has to be done towards the sky, like that. નીચેની બાજુ કેમ નહીં? Retractor has to be retracted any tissue towards the sky so that surgeon can get maximum area to be seen. Only thing is they ask is in this retractor, both in the Doyens and Langenbeck, the triangle area, this triangle, it is for what? બધા એમ કહે કે હોલ્ડ કરવા માટે, નોટ હોલ્ડ કરવા માટે નથી. This is just to make the instrument lighter. અધરવાઇઝ પેલો ફર્સ્ટ યર હોય બિચારો થાકી જાય, ઓલરેડી એક્ઝોસ્ટેડ હોય અને 2 કલાક 3 કલાક 4 કલાક સર્જરી ચાલે. See, nowadays better equipments are available, self-retaining are available, and nowadays we do majority by laparoscopy so that these kind of problems we don't face. But in majority surgery, whenever you are doing these using these retractors, the fenestrated retractor is just to decrease the weight of the instrument. Catspo and Doyens, and so these are all types of retractor. A retractor માં તમને most of the times કે which surgery it is used અને તમને laparotomy પૂછી શકે, what are the indications of laparotomy, what common incisions you put for the laparotomy. Scoop જ્યારે પણ આવે ત્યારે this is for the debridement. When area there is a slough, તો તમને બધી definition ત્યાં બી પૂછી શકે, what is slough, what is surgical removal of slough is called as, or in other word, what is debridement, what is surgical debridement, what is chemical debridement, right? Everything can be asked. This is used after doing debridement, any debridement, particularly diabetic foot, right? Cheatel's forceps, what is this? Cheatel's forceps used for, this is commonly kept in one bottle, big bottle. From there you can take out the instrument from that tray anywhere else so that there is a continuation of the disinfection is there. This one is Mixter's forceps. Mixter's is આગળથી it is 90 degree. આગળથી 90 degree હોય. This is used in open surgery, particularly in deeper structures, to do ligation of the pedicles. Suppose you are doing nephrectomy, you are doing cholecystectomy, you are doing splenectomy. This is the instrument which is most commonly used to ligate the pedicle, right? Coccus, previously it was commonly used In thyroid surgeries, there is a teeth like tooth in one side and one on one side. You can hold the tissue, so that the cockers was most commonly used for thyroid surgeries. Something about laparoscopy. What is laparoscopy? How you do? The first and foremost thing that you do is, first you create a pneumoperitoneum. Then, so that you create a pneumoperitoneum, abdominal wall comes up, the intestine goes down. You apply the position in such a way that you will get a space to work on. Suppose you want to do cholecystectomy, so that you don't injure the bowel. So you first and foremost you apply the gas inside. CO2, carbon dioxide, is insufflated first. For that, Varys needle is commonly used to create pneumoperitoneum. So this is Varys needle. There are two ways you can do pneumoperitoneum. One is by Varys needle, one is by open method, that is Hassan's cannula. તો તમે ઓપન મેથડ એટલું બોલો તો બી ફાઇન. અમ્બિલિકસ ઉપર ઇન્સિઝન મૂકીને you directly cut the peritoneum, you enter it and then you put a trocar and then you apply CO2. Because you are doing it under vision, by open method you are not injuring any important structure at the when you are creating a pneumoperitoneum. So this is Varys needle, can be asked. Maximum 3 to 4 liter per minute only gas can go. These are the laparoscopic trocar and cannula. The first and foremost 10 millimeter trocar is introduced, so that from there camera port will go. એક વખત કેમેરા અંદર જતો રહ્યો through umbilical, then under vision બાકીના જેટલા required trocar હોય you can put down, right? So these are the laparoscopic instrument. This is hemostatic forceps, જે આપણે commonly artery forceps કહીએ છીએ. આ laparoscopy માં we call it Maryland forceps, બરાબર? It is for the dissection. These are the scissors. These are the laparoscopic graspers. Clip applicator. Whenever you are doing laparoscopic cholecystectomy, you have to apply a medium, small, large clips to clip the cystic artery duct. Most of the times, so you are doing laparoscopic nephrectomy, you want to clip the pedicle. This is normal clip applicator. Then there are vascular clip applicators are also available. But આ કઈ મૂક્યું હોય તો તમને ખ્યાલ આવે કે this is nothing but a clip applicator. એટલા માટે મેં ખાલી આ ફોટો મૂક્યો છે. See, this is a needle holder, laparoscopic needle holder. Whenever you want to do endosuturing, suppose you are operating cholecystectomy, or you are operating there is a Meniere's syndrome. What you do? You do partial cholecystectomy and the gallbladder stump you have to close. Then you have to close with these laparoscopic needle holders. Again, these are the tackers. Tackers are nothing but staple pin, so that you do laparoscopic hernia. Two types of laparoscopic hernia. જો ટેકર મૂક્યું હશે તો બે પૂછી શકે, what is TAPP and what is TEP. TAPP hernia, transabdominal preperitoneal. You go inside the abdomen and then you enter into the peritoneum. Then you go preperitoneal. Then you put a mesh. પછી peritoneum બંધ કરીને બહાર આવો. અને TEP is totally extraperitoneal. કે તમે પહેલેથી જ પ્રીપેરિટોનિયલ પ્લેનમાં જાઓ છો, ત્યાં ડિસેક્ટ કરો છો અને ત્યાં મેશ મૂકીને બહાર આવો છો. બંનેની અંદર જ્યારે whenever you want to fix the mesh, this is the best. This is why it is used as tacker. Laparoscopic cautery hook. This is again used for dissection, and there is a hook is also available, and then there are spatula also. This is typically used when you have done cholecystectomy and you want to separate the gallbladder from the liver bed. Colostomy bag, skin staplers. ખાલી ફોટા મૂક્યા છે, તમને ક્યારે જોયું નહીં હોય તો ખબર નહીં પડે. એકવાર ખાલી જોઈ લો. પછી સ્કિન સ્ટેપલર્સ, ડિફરન્ટ ટાઈપ ઓફ સ્કિન સુચરિંગ, બરાબર? હોરિઝોન્ટલ મેટ્રેસ એન્ડ વર્ટિકલ મેટ્રેસ સુચર્સ. વોટ ઇઝ ધીસ? ધીસ ઇઝ ફોર STG, Humby's dermatome. Humby's knife or Humby's dermatome for doing STG. So what is difference between STG and FTG? Split thickness graft and full thickness graft. Indications of STG, in which patient you will do and all not. So we start with X-ray. X-ray I will not take much time. Just an outline. Commonly asked questions kya છે, ક્યાં તમે mistakes કરો છો, right? X-ray કાયો? First and foremost, whether it's a plain or specialized procedure. Specialized procedure कहीं भी हो सके. Barium meal, barium enema, barium follow through. It can be anything, right? So intravenous urography, intravenous pyelography, whatever it is. તમારે ખાલી એ જ જોવાનું છે કે whether it is a plain x-ray or specialized procedure is done. Number one. Number two, in this most of the times everything is written because હવે બધા digital x-ray થઈ ગયા છે. એટલે patient નું નામ, age, whether patient is male or female, everything is written most of the times, right? And even time is also written, date and time is also written, which area it is also written. So most important thing that you have to look for is whether it is a plain or specialized procedure is been done. So this is a plain x-ray chest showing plain x-ray chest region. So region, chest or abdomen, whether it is PA or AP. What is PA view and AP view? Posterior anterior, antero posterior. આપણે x-ray chest હંમેશા PA કરીએ. PA means it is the direction of the x-ray. The ray transmit from posterior to anterior. So plate ક્યાં રાખવાની? આગળ રાખવાની કે પાછળ રાખવાની? આગળ, બરાબર? X plate. So whichever area where you put a plate nearby, that area will be seen very nicely. એટલે આપણે x-ray chest PA માં posterior anterior લઈએ કારણ કે we want to look for the lung fields, right? So for that it is x-ray chest PA. So whether it is PA view, AP view, whether the position is standing or supine, if you can make out, that is very good. Both the time side diaphragms you can see, so that you can say that this is x-ray standing or standing position. Then important thing is to identify the bony landmarks. કે કયા landmarks છે? What is normal? Start looking x-ray from above downwards. First and foremost, see the bony landmarks. Is there any bony fracture or not? Then you look for the radio opaque shadows. Is there any radio opaque shadow or not? And then at last, જો examiner જ્યારે પૂછે ને ત્યારે જ તમારે બોલવાનું, બરાબર? કે આ શું ડાયગ્નોસિસ છે? બધામાં એક્સરે, ઇન્સ્ટ્રુમેન્ટ, સ્પેસિમેન કંઈ બી હોય, પહેલેથી કહ્યું સર ધીસ ઇઝ એન એક્સરે ફ્રી ગેસ, પેશન્ટ માઇટ બી ઇન પેપ્ટિક પરફોરેશન. તો એક્ઝામિનર શું પૂછશે પછી? So what is your interpretation? If examiner asks what it is, describe the x-ray, then you describe. Then he will ask what is the probable diagnosis. Then let him ask 10 questions, whatever he wants to ask, right? So this is the way questions are asked, right? Okay, what is the likely diagnosis? Common clinical presentation. Suppose free gas under diaphragm છે, તો examiner શું પૂછશે તમને? So what is the diagnosis? તમે એમ કહેશો free gas under the right dome of diaphragm. So in which condition this occurs? It occurs in hollow viscous perforation, right? What are the clinical presentation? How a patient of peritonitis will present to you? Suppose there is a peptic perforation with peritonitis, how the patient will present? What will be the symptoms? What will be the clinical signs? How will you proceed further now? Chalo free gas aayo, what will you do now? So whenever examiner asks you anywhere, even short case ke long case માં ભી તમને પૂછે what is management? તો management includes investigation and treatment. Sometimes x-ray માં ચલો air fluid level છે, there are multiple air fluid levels suggestive of intestinal obstruction. Now how will you proceed? Then you have to say that sir, I would like to perform further test, sonography or CT scan, whatever, depending upon the clinical condition of the patient. So first and foremost, never say sir, I would go for laparotomy, I would go for surgery. So management might be medical, might be surgical, but management depends only and only when you can diagnose the disease. So to confirm my diagnosis further, I would like to go for investigation like ultrasonography of abdomen and SOS CT scan of abdomen. So this is the way you should answer. So everything can be asked from single x-ray. Suppose this is the x-ray. So this is a plain x-ray chest PA view. Whenever there is pneumothorax or hemothorax x-ray, is there any blunting? Then you have to say, you look for the rib fracture. Are there any rib fracture seen or not on this x-ray? Every time you start looking from above to below, clavicle fracture છે કે નહીં, try to count the ribs, whether the ribs are normal or not. Most of the times UGની એક્ઝામમાં એવા એક્સરે મૂકે કે તમને આમ ઉડી નાખે વળગતું હોય, દેખાતું જ હોય કે આમાં જ આ બે રિબ ફ્રેક્ચર છે. અને મલ્ટિપલ રિબ ફ્રેક્ચર હોય તો શું જોવાનું આપણે? What is flail chest? Flail chest is paradoxical movement of the chest wall when two or more ribs are fractured at more than one place. એટલે સપોઝ 4th, 5th, 6th rib fracture છે તો એ રીબ એક જ જગ્યાએથી ફ્રેક્ચર ના હોય, આગળથી ફ્રેક્ચર હોય ને પાછળથી ફ્રેક્ચર હોય. ધ ઇમ્પોર્ટન્ટ થિંગ ઇઝ ઇટ લીડ્સ ટુ ઇન્સ્ટેબિલિટી ઓફ ધ ચેસ્ટ વોલ. There can be inspiratory in drawing. તમે ઇન્સ્પિરેશન કરો તો ચેસ્ટ વુડ એક્સપાન્ડ ના થાય, એ વખતે ચેસ્ટ વોલ અનસ્ટેબલ થઈ ગઈ છે, તો that is called as flail chest. So this is the commonly asked questions. What is CP angle? So there are two CP angles. નીચે જે દેખાય છે that is costophrenic angle, ribs and diaphragm, right? And another one is cardiophrenic angle, right? So one is cardiophrenic angle, one is costophrenic angle. The commonest asked question is that when CP angle is obliterated, કેટલા ml fluid ભેગું થાય તો CP angle obliterate થાય? At least 300 ml. At least 300 ml fluid is collected, either effusion or blood or pus, anything. Then and then only the CP angle will get obliterated. Then there are different causes of pneumothorax. What is tension pneumothorax? See, these are the commonly asked questions. From these X-ray, આ X-ray હોય એની અંદરથી આટલા question તમને પૂછી શકે. So tension pneumothorax is nothing but there is a one valve. Patient will inspirate but it will not come out. Most of the times major tracheobronchial injuries. So that every time, or is there any sucking chest wound? Open થઈ ગયું હોય, chest માં direct injury હોય, whenever patient takes inspiration, the air will come in. But in expiration it will not go out, it will act as a valve. So progressively that side of the lung will collapse. Then there is a, even it can, suppose right side injury છે તો એ આખું heart ને બી opposite side push કરે. There is going to be a midline shift of the heart, there can be, and patient can die in minutes. So what is the management? You have to put a wide bore needle in the second intercostal space, so that you can save the patient. You get by a time to do further procedure. And the further management is, trauma further management is, you put an intercostal drainage tube. That will save the patient immediately, right? Put an intercostal drainage tube. ICD tube બતાડે અથવા એક્સરે બતાડે, એની અંદર તમને ICD ઇન્સર્શન કઈ રીતે કરવી, ક્યાં કરવી એ તમને પૂછી શકે. What are the complications? What is safety triangle? Where will you put the ICD? So either anterior axillary line or mid axillary line in between 5th and 6th intercostal space, and these are the two ribs, 5th rib and 6th rib. So where will you put? Lower border of the upper rib or upper border of the lower rib? So upper border of the lower rib you should not put, because there is, ribs are going like this, there is one groove in the rib in the lower border, and the intercostal vessels and nerves are running like this. It from posterior to anteriorly it is coming. So if there are two ribs, you always should put a upper border of the lower rib. Put an ICD at the upper border of the lower rib. In the safety triangle, mid or anterior axillary line, patient should be in either in sitting position, not in supine position. And you have to put an ICD in which direction? Upwards, backwards and posteriorly, or upwards, backwards and posteriorly. So it should not come anteriorly, it should go posteriorly, upwards and backwards. This is the direction in which ICD should go. Previously it was taught that you have to put ICD in second intercostal space if there is pneumothorax, because air is going to go up. But most of the times isolated pneumothorax થાય નહીં. It is always associated with some kind of hemopneumothorax. So putting an ICD in 5th intercostal space is not going to cause any problem, right? So X-ray chest, you must know, these are the commonly asked questions. Suppose you have put an ICD in a pneumothorax. So now what? Most of the times, 90% of the times patient will be fine, more than 99% time. But in 1% case, if there is a major injuries, there is going to be continuous air flow coming out through the ICD, right? In that case, patient ખરાબ થાય વારે, એટલે most of the times patient ને major tracheobronchial injury હોય, that patient might require resuscitative thoracotomy. So indication of resuscitative emergency thoracotomy is, one is persistent major pneumothorax or major air leak, First, two, you have put an ICD for hemothorax. Put an ICD, more than 500 ml of blood has came, more than 1 liter blood has came stat, or more than 500 ml blood comes for continuously 2 hours. That is an indication that you have to open up because there is a major vessel injury inside. So you have to go for emergency resuscitative thoracotomy. This is the only thing that can be asked. પછી આવા એક્સરે મૂકે શું દેખાય છે? You should be able to spot the ICD. Can you see the ICD intercostal drainage tube? Where it lies? Where it's going? The tip, everything you can be seen very nicely, right? Again in this, can you see on the right side it was kept but it was going down, right? So then again it was reposited. After reposition you can see the right side lung is opened up. Lung collapse હતું, right side આખું ધોળો ધબ્બો હતો, right? એટલે lung, complete lung collapse on right side માંથી right side નું lung open થયું છે. But in right side lower there is air fluid level. Second X-ray. That means કે હજી still there is some fluid. It will take time to drain, right? પણ તમને ખાલી એટલું ખબર હોવી જોઈએ કે ICD છે, ICD નાખી છે અને whether it is normal or not. અને જો હજી ઉપર લખ્યું છે portable. પેશન્ટ અનસ્ટેબલ હોય ને ત્યારે ત્યાં વોર્ડમાં જ, આઈસીયુમાં જ ત્યાં જ થાય અને સુપાઇન પોઝિશનમાં થાય. Air fluid level, more than 3 air fluid level are there, should is indicative of intestinal obstruction. Intestinal obstruction, 2 or 3 commonly asked questions. One is whether it is small bowel obstruction or large bowel obstruction. How to differentiate? Multiple central abdomen, multiple air fluid level indicative of small bowel obstruction. And a small bowel obstruction માં જ્યારે you can see on this side, left side up, right? You can see multiple valves. That is called as valvuli conniventis or concertina appearance. That is classical of jejunum. And ileum is characterless. Ileum is clear. કારણ કે એમાં mucosal folds હોય, jejunumમાં multiple હોય ને એકદમ densely packed હોય. એટલે એ તમને jejunum દેખાય. And what is air fluid level? કે intestinal obstruction થાય એટલે over a period of time there is obstruction, આગળ fluid જતું નથી. It will be lying there only, so that the air will go up, fluid will go down, then there is a separation of both these two. That's why it is called as air fluid level, right? And large bowel obstruction, most of the times it is in the periphery. Number of air fluid levels are less. Large bowel obstruction મોટે ભાગે elderly માં હોય, elderly male or female. So it is in the elderly, that's why you should look for that, right? Causes of intestinal obstruction પૂછી શકે, right? So how will you answer? You will answer like two way. One is it is whether it is a functional or it is organic. Functional means parasitic ileus. Organic means there is some pathology. Pathologically ત્રણ રીતે divide થાય: intraluminal, intramural, that is within the wall, and extramural, that is outside the wall. Commonest cause of small bowel obstruction intraluminal are worms, gallstones, foreign body, trichobezoar. These are the things that are lying within the lumen that can cause obstruction. Within the wall, any cause that will give rise to stricture formation. The causes of stricture may be small bowel stricture, tuberculosis. Second cause is Crohn's disease. Two common causes, right? Outside the wall is adhesions. Intestinal adhesions, they can be bands. The commonest cause of intestinal obstruction is adhesions or bands. That is an MCQ, neat MCQ question, right? The commonest cause of small bowel obstruction is adhesions or band. એટલે patient ને previous laparotomy થયેલી હોય તો first cause એ જ હોય. Any patient comes with intestinal obstruction, you have to look for whether is there or not, right? Again, air fluid level, you can see the Ryle's tube lying inside. On both the sides, white is the diaphragm. See on the left side, and beneath that there is a free gas. Now, free gas under the diaphragm, that you have to speak. Normally, there is a gas shadow. There is some aerophagia. તમે ખાઓ થોડી air તો અંદર જવાની જ છે. એટલે left side gastric fundus shadow is going to be there normally. but free gas mainly on the right under the dome of diaphragm is suggestive of hollow viscous perforation. તો આ ગેસ આવે ક્યાંથી? બધા એમ કે લ્યુમન માંથી લીક થઈને આવી જાય. It can be, but the commonest is it is a gas forming organism, mainly E. coli, that causes that formation of this gas. So examiner will ask what are the signs of peritonitis, what is the clinical presentation, how will you manage this case, what are the commonest causes of small intestinal perforation or hollow viscous perforation. Suppose India માં free gas સાથે patient આવે તો commonest cause શું હોય? Peptic perforation, right? Second is enteric perforation, that is enteric fever. So these are the commonly asked questions. Tuberculosis, what are the types of tuberculosis, and all this can be asked commonly, right? There is one free gas and confined gas, that you have to differentiate, right? Again, right side you can see the free gas, mota free gas both the sides. Then there are different signs. Coffee bean sign, that is classical of sigmoid volvulus. So then the question will go, what is volvulus, what is intussusception, what are the different presentations, theories, what are the treatment options, everything will be like that. But on the right side, commonest organ that causes volvulus is sigmoid colon, second is cecum, and third is gastric volvulus can occur. Commonest biggest મોટું આખું intestine જો left side માં દેખાય છે ટાયર જેવું right side માં, so that is coffee bean sign, તમને coffee bean જેવું લાગે પણ આખું sigmoid colon આખું distended છે. So the sigmoid colon is the commonest area where it twists around itself. Here you can see transverse colon in the midline. Now this is X-ray showing renal calculus. But exam માં તમારે શું બોલવાનું? So this is a X-ray of KUB region, kidney ureter bladder region, showing radio opaque shadow on the right side. Right side where? So you have to calculate the vertebrae. How will you calculate the vertebra? 12th rib is attached to T12 vertebra. So lowest rib that you can see is T12. Then comes the L1. So this is near the transverse process of L2 vertebra. This is near the transverse process of L2 vertebra, right? So now examiner will ask what are the different types of stones and how will you further manage this patient. What will you do now? Suppose આ X-ray સાથે patient તમારી પાસે આવ્યું તો what will you do? What investigation would you like to go for? So it has to be intravenous urography. You want to look for the renal function, and before going for intravenous urography you have to go for sonography. That will give you an exact idea about the stone. Is there any calcium dilatation or not? Pelvic calcial system, that side kidney, any signs of pyonephrosis or not? So many things you can get from sonography. So first and foremost is sonography, then intravenous urography, then you will go for definitive management. આમાં શું કરવાનું? Definitive management is this is a bigger stone, so more than 1.5 centimeter stone you have to go for PCNL, percutaneous nephrolithotomy, right? Which type of stone it is? So there are two types of stone, phosphate and oxalate. Which is better to have? Which stone is better to have? Examiners exam માં રીતે પૂછે કે ભગવાન કહે છે કે તને સ્ટોન થશે પણ કે ત્યાં કંઈક સારા કામ કરેલા હું તને ઓપ્શન આપું છું કે તને ઓક્ઝલેટ સ્ટોન થાય કે ફોસ્ફેટ સ્ટોન થાય, તો તમે કયું ઓપ્શન સિલેક્ટ કરશો? This is the way examiner ask you. So which is better? Oxalate. Oxalate is a multiple spicules over the stone. Stone સાવ નાનો હોય ત્યારથી it start producing symptoms. It is very painful. It causes hematuria. While phosphate stones are they become very much big, so big that stagon calculi થઈ જાય આખા, and there is complete renal shutdown on that side. Still the patient might not have any symptoms. Similarly, they ask in thyroid also, which type of thyroid malignancy you would like to have. કે તમને મેલિગ્નન્સી તો થશે જ પણ કઈ ટાઈપની, ફોલિક્યુલર કે પેપિલરી? સો વિચ ઇઝ બેટર ટુ હેવ? વિચ ઇઝ લીસ્ટ પ્રોબ્લેમેટિક? પેપિલરી, because it is lymphatic spread. local spread જ હોય એનું. Follicular have a hematogenous spread. It can go spread anywhere in the body. But papillary usually local is spread હોય એટલે તમે કરી શકો. If you do total thyroidectomy and sometimes whenever there are lymph nodes are enlarged, you do that part of lymph node dissection, patient should be fine. This is urinary bladder calculi. Again એની અંદર ઘણીવાર એક્સરે ધ્યાનથી જુઓ મલ્ટિપલ લેયર્સ દેખાય because phosphate stone develops in infected urine and these are all multiple layers around that. ERCP ની પ્લેટ કદાચ મૂકી શકે તમે ક્યારેક જોઈ હોય તો તમને ખબર પડે. ERCP is endoscopic retrograde cholangiopancreatography. એટલે એમાં શું કરે CVD માં સ્ટોન હોય you do endoscopy, upper GI scopy, side viewing scope, it goes from esophagus, stomach, duodenum, then you cannulate the ampulla of Vater, then you go inside, you do dilatation or pre-cut so that you open up the ampulla and from there you do ballooning and basketing and remove the CVD stone. Patient is having obstructive jaundice. So what you can do is, this is the scope and the area પાછળ જે દેખાય છે આખું dilatation એ આખું dilated છે. Common bile duct is totally dilated. So this is a plate of ERCP. One more plate in which you can see this stent. Can you see stent on right side? Akho double J stent. This is typical done in obstructive jaundice CBD stone. CBD stone કાઢ્યા પછી you put a stent inside and you come out so that patient will have no obstructive jaundice. Progressively the jaundice will be relieved. After 6 weeks you can remove the stent. Again this is MRCP, same thing but magnetic resonance cholangiopancreatography. You can see gallbladder, common hepatic duct, common bile duct, everything pancreatic duct. PD is pancreatic duct. ક્યારેક પ્લેટ મૂકી હોય તો તમને ખબર પડે. This is chain of lake appearance, classical multiple stricture dilatation. In between the strictures there are dilatation હોય ત્યાં આગળ multiple stones થાય pancreatic duct માં. This is classical of intravenous urography. We already discussed intravenous pylography or intravenous urography can be asked. ખાલી આવી પ્લેટ હોય યાદ રાખવાનું. રાઈટ સાઈડ આખું ureter દેખાય છે નીચે સુધી. ઉપરથી pelvic alysial system on left side, it coming down and down. So dye is coming down. Right side it might be non-functioning or it might be peristalsis. Peristalsis આવે right side ureter નો તો આખી dye નીકળી ગઈ હોય. So that also can cause a picture. This is for RGU, for urethral stricture. આ ખાલી plates તમને બતાવવા માટે જ છે urethral stricture માં કેવું દેખાય. And you can do MCU also, micturating cystourethrogram. Commonly done is distal lupogram is done whenever you are doing any colostomy તમે કરી છે તો colostomy close ક્યારે કરવાની? Distal stricture હોય કંઈ perforation હોય તમે કરી નાખો તો fecal fistula થાય. એટલે હંમેશા જે distal loop હોય એમાં ડાઈ નાખીને આખું જોવું પડે કે distal બધું clear છે. Now you can close. So before doing any temporary colostomy or ileostomy closure you have to go for distal lupogram. This is classical upper core deformity, carcinoma esophagus, body, seen in barium swallow, pyloric stenosis. See, these are the classical pictures and these are actual pictures of my patients, right? Over a period of time we have collected so that it can be shown. Barium meal follow through. What is meal follow through? Previously અમે cox abdomen માટે કરતા હતા, but nowadays because of the availability of good CT scan, oral plus IV contrast CT scan, everything is very nicely seen. એટલે nowadays we are not doing very frequently this barium. કારણ કે barium perforation થાય and barium peritonitis is one of the worst to have, right? Again this is barium enema. You can say that there is a ascending colon mass. Mammography most of the times તમારા એક્ઝામમાં નહીં પૂછે પણ મૂકે તો તમને ખ્યાલ આવવો જોઈએ કે this is mammography. Only thing that is needed from you is what is BI-RADS and in BI-RADS what is malignancy. You must be able to tell that in BI-RADS 2, BI-RADS 3, BI-RADS 4 what is that you must know. That's it. Examiner wants કે આ mammography છે તમને ખબર હોવી જોઈએ, number 1, and number 2 which are the signs of malignancy. CT angio, હમણાં સાહેબે ભણાવ્યું what are the common causes. Most of the times Doppler will give you everything, but three things Doppler will not give you. That one is distal runoff, second is collateral circulation, and third is the calcium scoring. આપણે એન્જિયોપ્લાસ્ટી કરવી કે બાયપાસ કરવી કઈ રીતે ખબર પડે? In which patient you will not go for angioplasty? Which patient you will not go? In which there is significant calcification. Significantly calcified vessel હોય અને તમે બલૂનથી ડાયલેટ કરવા જાઓ તો ફાટી જાય. The pliability is lost. So for that in angiography calcium scoring is done. That calcium scoring is very important and that you cannot see in Doppler because it is non-invasive. તમને ડોપલરમાં બધું દેખાય ક્યાં બ્લોક છે શું છે, પણ ડિસ્ટલ રન ઓફ ના દેખાય, કોલેટરલ સર્ક્યુલેશન ના દેખાય અને these three things you cannot see. બાકી તમને જો આ પિક્ચર મૂક્યું હોય ખાલી એટલી ખબર પડવી જોઈએ કે નોર્મલી શું છે. It starts from where? It starts from the aorta, bilateral common iliac, it is coming down. કોઈ બી જગ્યાએ તમને બ્લોક દેખાય કહી દેવાનું કે સાહેબ આ જગ્યાએ બ્લોક છે. બરાબર? Commonly asked in PG, most of the times UG માં નથી બતાડતા, પણ I think that is fine enough. બધા exhausted છો? Okay, thank you. Any questions? Sorry. I had kept it last time because the grant surgery grant revision was on 14th February. So last year when I took lecture I kept this because we know only male and love.